Thank you, Dr. Kwaya, for your introduction. And hello, the friends from. Good morning, friends from Europe, and good afternoon, friends from Asia. Let's share about our experience in CEUS LI-RADS in our clinical practice. Liver cancer has a very high disease burden worldwide, according to a recent. Okay, here we go. Liver cancer has a heavy disease burden worldwide. According to recent published literature, liver cancer is the 6th most common cancer globally and the 4th leading cause of death from cancer, with annual incidence of more than 840,000 new cases. The risk of liver cancer is exceptionally high in cirrhosis population, with a reported annual incidence rate of 3% to 8%. This situation is even worse in China. And currently, ultrasound alone or combined with alpha-fetoprotein as a screening or surveillance tool among patients at high risk for HCC, especially in patients of cirrhosis or patients with chronic hepatitis B, was recommended by several national and international professional societies. Here is some examples of from the AASLD, their recommendation for patients who should under ultrasound screening. Imaging modality, imaging diagnosis of hepatocellular carcinoma can be challenging, especially for small HCCs and in patients with advanced cirrhosis. Contrast-enhanced CT, MI, and contrast-enhanced ultrasound has been widely used for diagnosis of patients with nodules detected in surveillance ultrasound. Liver imaging reporting and data system was initially developed for CT and MI, and it was expanded to include contrast-enhanced ultrasound in 2016 and updated in 2017, applied in high-risk patients for HCC. This system allows the radiologist community to apply consistent terminology, reduce imaging interpretation variability and errors, enhance communication with referring clinicians, and facilitate quality assurance and research education. Compared to contrast-enhanced CT and contrast-enhanced MRI, contrast-enhanced ultrasound has higher temporal resolution, lower allergic rates, and no toxicity to kidney. Their system contrast-enhanced ultrasound has a high pooled per lesion sensitivity and positive predictive value. Diagnostic parameters used in contrast-enhanced LI-RADS include the 4 parameters: nodule size, arterial phase, enhancement pattern, and washout onset timing and degree. Arterial phase hyperenhancement includes enhancement in whole or in part. That's a main feature for LI-RADS-5 lesions, and rim enhancement for LI-RADS-M lesions, and peripheral discontinuous nodular enhancement for LI-RADS-1 lesions. Later mild washout refers to hepatocellular lesions, including LI-RADS-3, LI-RADS-4, and LI-RADS-5 lesions. Pathologically, low-grade dysplastic nodule, high-grade dysplastic nodule, or hepatocellular carcinoma. Early marked washout was a feature for malignancy, but not specific for hepatocellular carcinoma. Inflammatory mass or metastasis may also present this feature. Based on the 4 parameters: nodule size, arterial phase enhancement pattern, onset, washout onset timing, and degree, the focal nodule or focal liver lesions was classified to each category according to the algorithm of contrast-enhanced ultrasound LI-RADS, with different level of risk for HCC. In retrospective study, with 350 consecutive contrast-enhanced ultrasound detected nodules in cirrhotic patients, using CT, MRI, or biopsy as a reference standard, the probability of hepatocellular carcinoma associated with each CEUS categories was LI-RADS-M 40%, LI-RADS-5 98%, LI-RADS-4 88%, LI-RADS-3 60%. However, this system is relatively new and needs more study to validation. According to our study, we should lower rates of HCC probability in LI-RADS-3 lesions. For LI-RADS-1 lesions only applies to cysts, hepatic fat deposition or sparing. If there is uncertainty in the diagnosis, categorized as LI-RADS-2 or higher. This is a patient with chronic hepatitis B, focal liver lesion detected on pre-contrast ultrasound in the right lobe. Liver stiffness didn't indicate cirrhosis. Arterial phase shows peripheral discontinuous nodular hyperenhancement and filling graduate to the center, showing hyperenhancement in portal and lead phase in accordance with classic cavernous hemangioma, as LI-RADS-1 hemangioma definitely benign lesions. For CEUS LI-RADS-2 lesions is probably benign. In all phases with a diameter less than 10 mm or observation previously diagnosed as LI-RADS-3 and stable dimension for 2 years or more, probably cirrhotic regenerative nodule or low-grade dysplastic nodule. In cirrhotic liver, nodule less than 10 mm is common. If they show isoenhancement in all phases, they should be classified as LI-RADS-2. LI-RADS-3 includes 4 patterns. First, nodules larger than 10 mm, isoenhancing in all phases. Second, nodules at any size, arterial phase hypoenhancement without washout. Third, nodules smaller than 20 mm, iso or hypoenhancement in arterial phase with mild late washout. Fourth, nodules smaller than 10 mm, hypoenhancement in whole or in part without washout. LI-RADS-3 has an intermediate probability for HCC. This lesion was detected in a pre-contrast ultrasound, the hypoechoic nodule. This nodule shows isoenhancement in all phases. So this is LI-RADS-3 lesion. For LI-RADS-4 lesion, there are 3 types. First, nodule larger than 20 mm, arterial phase hypo or isoenhancement with mild and late washout. Second, nodule smaller than 10 mm, arterial phase hyperenhancement with mild and late washout. Third, nodule with a diameter larger than 10 mm, arterial phase hyperenhancement with washout. Let us share a few cases. This is a LI-RADS-4 nodule in a 60-year-old man with chronic hepatitis B. This hyperechoic lesion has a hyperenhancement in arterial phase and no washout in late phase. And this lesion was proved to be dysplastic nodule by pathology. This is another case, LI-RADS-4 nodule in a 53-year-old man with chronic hepatitis B, a hyperenhancement in arterial phase, and isoenhancement in that phase. Ultrasound-guided biopsy proved this lesion was a neuroendocrine tumor. LI-RADS-4, LI-RADS-5 is LI-RADS-5 refers to nodule with a diameter larger than 10 millimeter arterial phase hyperenhancement in whole or in part, but not rim or peripheral discontinuous globular enhancement with mild and late washout. CEUS LI-RADS-5 was designed to have a high positive predictive value near 100%. This is a LI-RADS-5 lesion, hyperechoic in pre-contrast ultrasound, hyperenhancement in arterial phase, and the contrast agent, the microbubbles washed out mild and late. We can see the washout in 1 minute and 51 seconds, and the degree of washout is mild. This is a hepatocellular carcinoma. If enhancing in soft tissue in vein was detected, but in portal vein or in hepatic vein, it should be classified as LI-RADS tumor in vein. Caution should be paid to differentiate tumor thrombosis from bland thrombus. Early arrival of contrast agents favor tumor in vein. We can see the soft tissue echoes. We can see echoes inside the portal vein, and in contrast study, this area is enhanced in arterial phase. So this case is contrast enhanced ultrasound LI-RADS tumor in vein. LI-RADS-M refers to lesions definitely or probably malignant, but lost basic to hepatocellular carcinoma. Rim enhancement followed by washout or early washouts or marked washout. This is a LI-RADS-M lesion in a 46-year-old woman with chronic hepatitis B. It's rim with rim enhancement in arterial phase and early washout. It was proved to be intrahepatic cholangiocarcinoma by pathology. HCC may also show early washout. It is reported that poorly differentiated HCC has higher rates to show early washout. In this case, this is a pronate. This LI-RADS-M lesion in a 60-year-old woman with chronic hepatitis B. This lesion was proved to be poorly differentiated HCC. Ancillary features refers to those features that may modify the likelihood of HCC. These features do not permit reliable classification of observations. Ancillary features cannot be used to upgrade categories to LI-RADS-5, but it can downgrade to LI-RADS-4. Ancillary features that favor malignancy include unequivocal diameter increase, normally larger than 5 centimeters, nodule-in-nodule architecture. Ancillary features that may favor benignity includes unequivocal diameter reduction or diameter stability for more than 2 years. There are also tie-breaking rules. If unsure about the presence of tumor in vein, do not categorize LI-RADS tumor in vein. If unsure between two categories, choose the one reflecting lower certainty. We can see LI-RADS-3 is the most lower with a lower certainty. CEUS LI-RADS also suggested imaging workup options and time interval for each category. You may go to the SAR website for more information. Thanks. That is my sharing of our experience in LI-RADS in clinical practice.
Thank you, Professor Lu, for very nice presentation. I really appreciate the quality of the images you showed to us, really astonishing, really nice. I have, now I am ready to collect the question of the audience. We have 10 minutes for questions, and I would like to ask you, what is the length of the scene clips you registered during the scan?
You mean the length of the scene loop we recorded or we scanning the patient?
Yes. What is the? Do you register scene clips during your scan? Static images? What do you do?
Yeah, we store the scene loops for the first 60 seconds, and intermittently after that, at you know, maybe 2 minutes, 3 minutes. If we see washout in 2 minutes, or we stop the the scanning maybe three minutes. If we do not see the washout in 3 minutes, we are scanning the patient up to maybe 5 minutes to avoid missing a very late washout of the contrast.
So you use the clips for the 30-60 seconds, and then you stop and resume your scan up to 5 minutes to detect eventually the evidence of washout. Is it right?
Yes, we scan the patient continuously in the first minutes, and scan the patient discontinuously, intermittently.
And this is
to save, to avoid distract the bubbles too much.
I think this is absolutely crucial, because I think this is the right technique to use, because otherwise you provide an excessive distraction of microbubbles in the plane. You are insulating. Yes. So absolutely. You have to minimize microbubble rupture by stopping the continuous scan on the first minutes, and then you have to scan and to stop and resume your scan in the following minutes. Absolutely.
Yeah. Yes.
There is one question. One people from the audience asking to see again the page 32. Can you show us your 30-second slide?
32.
Yes. Please click on it.
This one?
Yes. Okay.
Yeah. Yeah.
Can you show it to us? Can you send comment on the slides? Can you comment?
This slide, yeah, just SR. This is a website for the SR. You can download the liver imaging reporting and data system in this system, in the website. And this is the previous version, the CEUS LI-RADS 2016, and it's updated in 2017. So it is not the latest version. The website is the same.
Okay. There is another question, and the question is how to assess the degree of contrast agent washout. Do you feel it could be useful to use time intensity curve or simple by visual analysis? What do you think?
We usually by visual evaluation. And the time intensity curve is when we scan the patient, we seldom to fix the scanning. We may scan the patient, in the random, or we can move to other areas if there are. So that if you want to use the curve, time intensity curve, we must do a fixed scanning. You do not, you cannot move scan other areas for the to find other hyperenhancement, maybe other hyperenhancement nodules. So in our daily practice, we use video evaluation to see the washout, and we do not have the experience to use a time intensity curve to detect if there are any mild washout. But I think the visual evaluation is enough for clinical practice and more convenient.
But I think that the question is based on the figure you showed at the very beginning of your presentation, because you showed a very nice curve in which you see the crossing of the curve of the focal liver lesion and of the deviation liver parenchyma. And I think this is the reason of the question, because it can be useful, I think, if you have a fixed scan focalized in a particular region of the liver, so you can assess the different dynamic of enhancement in the lesion, in the deviation liver. That's the reason of the question, I think.
Okay. The time intensity curve, absolutely can be used to quantify the perfusing and the washout of the lesion, and which is very useful for especially for the adjuvant chemotherapy. Even for the to evaluate the response, treatment response. So I think this technique is useful in clinical practice.
I think that in some cases it is absolutely mandatory to use quantitative analysis, because in most of cases actually you can assess washout simply by visual assessment. In some cases you are absolutely, the washout is questionable, so it can be useful to have a simple quantitative software. I don't mean for sure a commercial software. It can be just a software which can allow you to assess the intensity of the lesion and the intensity of the additional liver in the same time frame, so that you can assess, you can realize if there is or not washout. I have another question for you. Actually, this is a question which could be a little bit tricky to answer, but what is the weakness of the present CEUS LI-RADS classification, if there is any weakness, in your opinion? Is there some weakness? Something should be changed? What do you think?
That's okay. That's a tricky, that's a tricky question. For me, I think the same is true for the contrast enhanced study of ultrasound. The weakness is the same as the ultrasound. For lesions that nice deep situated lesions, the penetration is a challenging. In that case, sometimes we increase the mechanics index to increase the penetration, and but in that way you will distract more bubbles. And second, if the patient with a big shape, when you encounter a big patient and or a patient with severe fatty liver, so that penetration also give you a very challenging thing. And those lesions that situated in the subdiaphragmatic area, that also challenging for ultrasound to scan. So one more thing is the ultrasound is dependent. So it requires much expertise to do a very good contrast enhanced ultrasound study. But this system, LI-RADS system, is developed to reduce the variations between different doctors. So I think that is true. There's shortcomings of pre-contrast ultrasound is also true in contrast enhanced study.
Okay, so you are seeing weakness in the ultrasound technique itself and not in the present version of CEUS LI-RADS. You don't identify any weakness in the classification LI-RADS itself. You are saying weakness in the ultrasound technique.
Yeah, one more thing I should add up is ultrasound is a focus study.
Yeah.
And yeah, focus study, you can evaluate one lesion at a time. You cannot scan the whole liver at the same time, not just as contrast enhanced CT or MRI. So ultrasound, contrast enhanced sound can be used to characterize the focal liver lesions at one at once, and you know, not for staging. You know, staging is not the the advantage of our contrast enhanced study. So that is also the shortcoming.
Fine. Thank you so much, Professor Lu, for your very nice and very complete presentation about the application of contrast enhanced ultrasound in the characterization of focal liver lesion, with particular emphasis on the CEUS LI-RADS. Thank you so much.